Hello, my name is Vienna LaFrenz and I'm the National Training Coordinator for Rehab Care. And today's topic, we are discussing BETI training, which is the late loss ADLs for nursing and CNAs. What we're hoping to accomplish with this training today is to ensure that we're capturing as much of the abilities that our patients have and being able to track exactly what is going on with them so that we are able to ensure proper reimbursement for the services we provide. So let's get started. Hello, my name is Vienna LaFrenz. I'm the National Training Coordinator for Rehab Care, and I'd like to welcome you to this video recording of BETI, accurately coding the late loss ADL for nursing and CNAs. Now, the reason we call this BETI training is because it stands for the 4 areas that the patient tends to lose last, and that is bed mobility, eating, transfer, toilet use, and if you record those areas accurately, you get a big yes. So that's why we call it BETI. So welcome to BETI. The objectives that we plan to accomplish during this training is we want to provide an enhanced understanding of the importance of coding bed mobility, eating, transfer, and toilet use correctly, explain what the definition of a late loss ADL is, provide the definitions of self-performance and ADL support provided, learn important coding tips, learn the definitions of each ADL. We're going to review examples of setup help for support provided. We're also going to review common coding errors and share best practices to improve coding. And we're going to introduce you to BETI. So why do we need to code correctly? Accurately coding bed mobility, eating, toileting, and transfers ensures appropriate reimbursement to match the care provided, to include the cost of the care when skilled nursing or rehab is provided. Now, this is really important. What many of us may not understand is that we are reimbursed at the facility level based off of the care that's being provided. And that care is identified through an assessment tool called the MDS, Minimum Data Set. And that minimum data set includes these 4 areas because of the fact that these tend to be the areas that the patient loses last. So therefore, being able to measure the performance of the patient throughout the course of their life allows us to use this method to determine how much the facility should be receiving to care for this resident or this patient. So what's included in that is everything. Everything we do, everything that requires to pay for the facility. So that means the patient's supplies, their medications, their food, their room and board, their laundry services, their equipment needs, their bed, if they require a specialty bed, a wheelchair, a walker, as well as oxygen use, as well as all of the staff salaries and benefits. So it's extremely important that we capture that care in order to cover all of those costs. Coding correctly must reflect the care provided. A surveyor may actually observe the care to ensure the care matches the ADL section of the MDS. So as you are providing care as a CNA or even as a nursing staff, they may actually, or even in rehab, they may actually watch the care that you're providing and then see how you code that care. And this is really important because if what we document in that MDS section or in that ADL section of our tracking sheet, if it doesn't match what the surveyor may think or what they observe, then they could actually take money back. So it's important that we actually capture the care provided. Correctly coding ensures the ADL section of the MDS is accurate. And like I said, that is the portion of the care that is reimbursed by Medicare and the regulatory bodies. So that's where there's a difference between what is called the end split. That is the RUG, which is the Rehab Utilization Group, and there's usually an A, B, or C component to it, which is called the end split. That helps us to define the amount of assistance that was provided and how many staff were used to provide that service. So what that means is that could be a difference between anywhere from $100 to $200 per patient day if we don't code it correctly. So if a patient scores as an A, for example, that means that they're relatively independent, that they don't need a lot of assistance. Whereas if they code as a C, that means that they really require quite a bit of assistance. They may be more of an extensive type of assistance. So therefore, that's the difference, where a C gets paid more, whereas an A doesn't. But if a patient requires that C level of service or performance, then we should capture it. It's important for proper care and safety for patients and staff. If we code someone as a limited assistance and we know that they've required more hands-on assistance than that, and somebody that is following your care, your colleague who is following the next shift, if we don't capture that level of care, we may be putting them at risk. So it's important that we capture that. It also ensures accurate discharge planning. Now, this is interesting. If you think about some of our patients or our residents who are planning to go home, or maybe to a lesser level of care, and we know that they fluctuate throughout the day. We all fluctuate in our level of function throughout the day. But let's say that we have a patient who tends to really decline a lot in the evening, and so they need much more assistance in the evening. To be able to see that trend can actually help us determine that this patient needs some assistance when they go home. And so when we're helping the family members decide what kind of assistance they might need or support, then we can give them that really good guidance that says, they tend to need more assistance in the evening. So if you're going to hire anybody or have some additional support at home, it would be in the evening. And in that way, we make sure that they have a safe discharge, that they're able to not return back to the hospital, and they'll be able to stay home or stay in that lesser level of care. It also ensures proper staffing pattern to reflect the complexity of the patient. So if we don't capture the complexities of all of the patients, then we may be short-staffed, and our support staff may be having to really pick up the slack and work in a very unsafe environment because we haven't staffed to the level of complexity that our patients deserve. Also, coding is a communication tool. It lets one department, one shift know from one to the other what's going on with that patient. It can also let us know if we're starting to see a decline in that patient, or maybe even an improvement. So it's a really good way in which for the whole interdisciplinary team to communicate. So when we're talking about the coding, there are two areas of coding. There's the self-performance component of it, and that's what the patient actually did. And then the second one is the support provided. That's the amount of staff that is needed to assist with that self-performance. So when we're coding the ADL self-performance, it's truly based on what the patient did, not what we think they should do. So 0, when we're coding a 0, that means that the patient is independent. They have no help from staff, no staff oversight, no hands-on assistance, no queuing, no nothing. They can do that task by themselves with no support whatsoever. 1 means supervision. No hands-on assistance given, just oversight, encouragement, or queuing. 2 means limited assistance. It means the patient is highly involved in the activity and staff assistance is required to provide guided maneuvering of limbs. No physical support or lifting is given. Then we have 3, which is extensive assist. The patient is involved in the activity and staff assistance is required to lift, partially lift, and or support the weight of the patient's limb or body, meaning weight bearing. So when we're talking about limited assist versus extensive assist, this is where I like to make it really easy. And that is when we're talking about the limited assist, this is where I talk about the hands up and hands down concept. What that is when we're talking about limited assist, it means that your hands are placed downward and you're not necessarily lifting any of the patient's weight. You're literally just guiding their extremities through movement. When we're talking about extensive assist, your hands are up, they're actually touching the patient's body, they're taking some of their weight. So for example, if you are working with a patient and they start to lose their balance while they're sitting, and you have to put your hands on their body to capture some of their weight and take some of their weight, you're taking on their weight. So that automatically scores them as an extensive assist. So when we're talking about guiding,
What that means is you're literally just guiding the hand to the desired location. So if you're working with somebody on a self-feeding concept and they're tremoring and you just need to help them with a smooth pursuit to their mouth, you're literally just putting your hand on their extremity and guiding it to their mouth. You're not having to take on the weight of that patient.
4 means the patient is totally dependent. Patient does not help whatsoever. Therefore, full staff performance is required each time we perform that task. 7 means the activity occurred only once or twice, and 8 means the activity did not occur. Now, that doesn't mean that we didn't provide any care for that resident. It just means during that shift, that activity did not occur. And we'll go through some examples of that. When we're coding the ADL support provided, that means the amount of staff that is required to perform and assist with that task. So 0 means no setup or staff assistance. 1 means setup help, no hands-on assistance given. But obviously, if we're providing some setup, that means 1 person helped with that, so that's where the 1 comes in. 2 means 1 person physical assistance. So that means we've had 1 person help with that, but you're coding it as a 2. 3 means 2 person physical assistance. That means 2 people were required to help perform that task. And 8 means the ADL activity did not occur during the entire period. Some important coding tips to remember is code the actual assistance provided, not what the patient should do, but the actual assistance that we provided. Code for the most support provided. Now, remember we talked about how the patient's level of function fluctuates throughout the day, so throughout your shift, that level of assistance might change. And so we need to make sure we're coding for the most support provided. So in that incident where I talked about where that patient lost their balance and we needed to support them, that doesn't mean that it happened every single time during that day, but during that shift, if that happened, you had to provide more support during that time. So we need to capture that. Do not code the assistance the patient should be receiving according to the care plan. It's what actually happened. Like I mentioned, the care plan is that guide that tells us this is how we should care for this patient. But again, the patient may be fluctuating throughout the day. And do not count assistance by family or visitors. Now, by no means do we want to discourage our families or visitors to provide that care. The reason we can't count it is because they're not being paid by the facility to provide that care. So therefore we can't code it. Now, we're going to talk about some situations in which you could still count for some of that assistance and not taking away from that time that the family has or the visitor has with that person. So the definitions for the 4 ADLs we're going to cover. When we're talking about bed mobility, it's how the patient moves to and from a lying position, how they scoot up in bed, how they turn side to side, and how they position their body while in bed, in a recliner, or other type of furniture the patient sleeps in. Now, I think this is one of our biggest areas of opportunity because I want you to think about it. How many of your patients truly do you feel can go from they do their transfer, they go from their wheelchair to their bed and they're sitting on their bed, and they can actually go from a sitting position to a lying position without any help whatsoever. Most of the time we're having to help them put their feet up on their bed, and then we need to scoot them up in bed. Now, do you scoot them up in bed just with one of you, or do we typically have 2 of us helping scoot someone up in bed? So in the example we were just talking about with the coding, if 2 of you are having to scoot that patient up in bed, how would we score that? You're right. We would score it as a 3-3, extensive assist requiring 2 people. Now, most of the time when we are scooting someone up in bed, to do that by yourself with 1 person puts you at great risk for hurting yourself. So in most of those cases, it does require 2 people. So we would always code that as a 3. And then turning side to side. Many times our patients can turn themselves in bed using the side of the bed, or they might have a little half a side rail that they can actually use to help them. but can they do it to both sides? Oftentimes our patients may be weaker on one side versus the other, so we may need to help them with that. So being able to capture that. When we're talking about definition for eating, it's how the patient eats, drinks, and drinks regardless of the skill. It does not include eating and drinking during medication pass like it used to in the past. It includes intake of nutrition by other means, so tube feeding, total parenteral nutrition, IV fluids administered for nutrition or hydration. Now, when we talk about this is oftentimes where that limited assistance comes in. Let's say we have that patient who is scooping that food and they're trying to bring it to their mouth, and because they have a tremor, it's impacting their ability to bring that food to their mouth, and so they're losing most of the food on their spoon or their utensil. And with a little bit of guiding, if we just took one finger or two fingers and we are guiding their hand to their mouth, they can actually make that smooth pursuit from the plate to the mouth, and they can actually ingest the food. In that situation, we would call that a limited assistance because we're not taking on their weight, we're just guiding it. But it allows that patient to get their food in. This is also a time when our family and our visitors like to actually assist with the self-feeding process. And as we know, self-feeding is a very social environment, and we don't ever want to take that moment or that time away from the family or the caregivers, because oftentimes that patient will eat more if they are with their loved one. So we don't ever want to discourage that because we're not getting paid for it. But what we can do is we can actually set up that tray for the patient prior to the patient's family getting there, or set it up for that family member when they're feeding. With that setup, what do we do with that setup help? We're coding it as a 1 because we're setting them up. Or you can also capture those snacks that occur. Now remember, it's not the med pass that we're capturing. What we're trying to capture is we give our patients snacks throughout the day. Is the family there to help them with that snack? Probably not. If we need to help that patient ingest or help them with that food as they're ingesting that snack, or they're taking bites of it or bringing it to their mouth, then we can capture that. So it's not just in the dining room and that major meal that we're capturing, it's throughout the day. So that's a really good opportunity for us. The next one is the definition of our transfers, how the patient moves between surfaces, to and from bed, chair, wheelchair, and to and from a standing position. This excludes to and from the bath or toilet, which is covered under the toilet use and bathing. Now, I think this is also another area of opportunity. How many times have you been working with a patient and you've been helping them with a transfer? And normally they might be able to do the transfer by themselves or with some standby assistance or maybe some supervision. But during this one time, they maybe lost their balance, or they needed some additional assistance to get their bottom into the chair. This is a perfect opportunity for us to capture that moment. And it's a good predictor that this person may be at risk for a fall. And if we didn't capture that additional assistance that we provided, then we're not capturing that risk of a fall. The next definition is on the toilet use, how the patient uses the toilet room, commode, bedpan, or urinal, how they transfer on and off the toilet, how they cleanse themselves, change their pad, maybe how they manage their ostomy or their catheter. Are they able to adjust their clothing? This does not include emptying of bedpan, urinal, bedside commode, catheter bag, or ostomy bag. Now, I believe this is another opportunity for us to capture correct coding. How many of your patients, as they're using the toilet in the toilet room, can actually manage their clothing as they're going from a sitting to a standing position, and manage their clothing by pulling their pants up, zipping, buttoning, and so on? How many of them can manage their adult undergarments, of being able to pull those up? Or in many cases, we have the tape that they have. Most of the time, not many. So we need to capture that amount of care. Also, how many of our patients actually clean themselves thoroughly or safely? Do we have to go back in and provide some additional cleaning? If so, we need to capture that time and think about, where is our hand placement? Is our hands facing towards the patient? Is it lifting? Is it supporting? If it is, then it's an extensive assist. Oftentimes we may not think so, but if we are having to take any of their weight, then it's considered an extensive assist. Now, if we're just helping them with buttoning their clothing or zipping up their pants, we're not taking on any of their weight. So that will be more of a limited assistance. So some examples of when to code setup help, which means one person support provided. Bed mobility. If we're handing the patient the trapeze on a bar, the staff raises half the rails on the bed for the patient to use and then provides no further help. The patient can then turn themselves, they can move themselves around in bed. That would be considered more of a setup help. We just set up the environment for them to be able to perform. Eating is we cut up the meat, we open their containers at meals, or we may be giving the patient one food item at a time, but then after that they're able to feed themselves. We're just setting up their environment. During transfers, if we're having to lock the wheels on the wheelchair or handing the patient a transfer board to perform their own transfer, again, that's a setup help. And toilet use, if we're handing the patient a bedpan or placing the articles necessary for the patient to change an ostomy appliance within reach, that's considered setup help. Now, some common ADL coding errors is that all the tasks of the ADL function are not assessed before coding that performance and not capturing the most dependency within the given area. So, for example, the patient is able to roll side to side in bed with the use of the side rails. So, pretty much they're considered 0 for independent. But if we're not assessing the patient's ability to scoot up in bed or sit up from a lying position or to be able to put their feet up in bed or out of bed, then we're not looking at the whole performance of that task. So therefore, we're setting them up for failure as well as our staff. Rolling side to side is the least amount of care that is usually required. Many of our residents are able to do that. Where they need the most support is literally in that scooting up in bed, which usually requires 2 people like we talked about. Or if they're going from a sitting up from a lying position, oftentimes we're needing to take their body weight. So already it's considered an extensive assistance because we are having to lift their body, lift a body part, or take some of their weight. And then of course when we're putting their feet up and out of bed, we're then taking the weight of their limbs and placing it in the proper position. Another example is the toileting. Looking at the transfer to and from the toilet must be assessed when coding the toilet use, in addition to clothes adjustment and donning of a brief. Now, as we know, that's really difficult. So even for some of our patients who may be having some balance issues, for them to take their hands off of the rail for support to then use both hands to make that clothing adjustment, if we weren't there, they wouldn't be able to do it. Also, the cleaning we already talked about. So if we're having to go in there and provide some additional assistance to ensure that they are clean and that they are free from any form of infection and so on, then that is that we are providing some cleaning. And then of course the catheter care. If we are needing to help within the catheter care of making sure that it is operating, that the catheter is working and so on, we need to capture that. And then not coding for the one-time issues, so that loss of balance we've talked about throughout this training. So while we're transferring or bearing the weights, the patient's weight during the transfer, or when they're sitting up in bed, bearing the weight of the patient's trunk. Again, those are predictors of a fall if we don't capture that. Supporting the patient's weight during bed mobility. Again, as we're scooting them up in bed, or maybe we're holding the leg in place while they scoot themselves up in bed. If we did not hold that leg in place, remember where your hands are. You're placing your hands on their leg, so therefore you're having to take on some of the weight of that leg. Or when 2 people are pulling the patient up in bed, that is a safety factor of making sure that we have 2 people scooting them up in bed. Some of the common ADL coding errors also is the peer pressure. Every other person is coding it this way. You may be a new staff member on the floor, and you see that one CNA or one nurse may be coding this patient as a higher level, but you see this person requiring more assistance. So a little doubt gets in there, and you think, ooh, maybe I'm doing this wrong. They've been here longer. They know this person better. Maybe I'm wrong. Go with your gut. Your gut is telling you you're not wrong. Code it the way that, based off of what we just discussed, and you will be right every single time. Or you might be questioned by others as to why you coded it that way. And oftentimes it's just to clarify. And maybe because the patient has been performing at this one level throughout the week, and then they had that decline, or just they started to have some fatigue, and so they required some more assistance. And so you coded it that correctly. Well, it's different. It's not the typical. So they may come and question you about that, and that's okay. Not taking the time to chart what actually happened today, just putting down what was charted the shift before. Now, many of our facilities now have electronic medical records, so we don't even see what is actually being coded from the previous shift. So in that situation, you're not going to actually be able to see what they did. However, if you're always coding what happened during your shift, during your care, and you actually take the time to do it, then that'll be very important. Many times you might have the electronic medical record device nearby, so you can actually code it right then and there. If you don't have something like that, and maybe you're still using the handwritten treatment records or ADL records, then it's important that you keep a notepad that that kind of reminds you what happened throughout the day, so you can actually capture those one-time incidences, or you can actually see what all you did, and then you can capture that when you go to do your coding. Another area is that CNAs are not understanding rehab's terminology, since it differs from nursing. In rehab, they have to use different terminology to show that the patient is making progress. So it doesn't always match the same terminology. When we say max assist, it's the same as extensive assist. But sometimes we may not understand that. When it gets into the really confusing ones like contact guard assist or min assist, in those situations, it's considered a limited assist, or in some cases, it might also be extensive assist. It really depends on where the hand's placement and if we are taking on some of that weight. So really understanding the difference between nursing and rehab's documentation. Now, in most cases, we should be encouraging our rehab team to use the same language when they're training staff, or when they're educating, or they're talking to other staff members about the amount of assist. So if this person is a mod assist for rehab, we would say this person is an extensive assist of 1 or 2 people, whatever ends up being. And not understanding the difference between limited and extensive assist. If you just think about the hands up and the hands down concept, and if you think about, am I taking on any kind of weight? Am I having to lift any of the patient? Then that's always going to be an extensive assist. But if you are truly just guiding and your hand is down and you're not having to take on any of that weight, it's going to be a limited assist, or it may be independent or setup. So some best practices to improve coding of late loss ADLs is to provide training and continued education on coding ADL with the CNAs to reinforce accurate coding. And this should be done many times throughout the year, not just a one time. Because as we know, bad habits can be established, and we may not remember certain aspects. So provide training on a regular basis. If you have a new CNA on the floor, shadow the CNA to ensure correct coding is occurring, and make sure they're learning correctly the first time. But then also, it doesn't hurt to shadow some of your seasoned CNAs to ensure that they are also remembering the correct coding. Establish a training program for new hires. You got to capture them when they're new so that they don't develop the bad habits in the very beginning. Establish a CNA mentor to monitor accurate coding. You know, you have those great CNAs that you just want to clone, and you want to have, multiple numbers. So pick that one that you know knows this really well, that knows how to train, that knows how to guide and encourage, and make that your mentor to ensure that accurate coding is being conducted. And validate this, that the CNA mentors and unit managers' accuracy of coding and understanding of the ADL definitions is accurate. Provide a quarterly refresher training and quiz. And then also use Betty for visualization and easy remembering of the 4 ADL components. Ask questions if you're not sure. So now I'd like to introduce you to Betty. Now most of you should have the booklet that we created for your reference. And this is Betty. Betty, again, stands for bed mobility, eating, transfers, toilet use. And if you did all that correctly, then yes. So throughout this booklet, you will see that we have highlighted many of the aspects that we've been discussing throughout this training. So if you have your CNAs, if you have your nursing staff members, your case managers carrying these little booklets in your pocket, then they can access it readily to ensure that they're capturing the care provided. So each of these handouts will actually go through all of the things we just discussed regarding the definition. So here's the bed mobility, eating, transfer, and toilet use definitions of performance, the coding that's required for the self-performance and the coding for the support provided, and then going through each of the aspects. We added pictures to help with some of that understanding so you could actually see how that patient should be looking as we are performing these tasks. So as you see with this independent with bed mobility, you can actually see that the patient's performing everything themselves. They're getting up out of bed, they're pushing themselves up from bed, and they're able to do that. No staff is present. With the supervision, you can actually see that the nurse is standing there with her hands off, and she's probably just giving some verbal cues to remind the patient to reposition themselves and potentially to use the side rail. But she hasn't even touched the patient, and she hasn't even provided any kind of assistance whatsoever. A limited assistance, as you can see, she's guiding the hand to reach for the side rail, but she's not having to lift it. She's just guiding. Limited, and then the second example is she's guiding the legs off of the bed, but she's not lifting. So she's literally just guiding them over, so then the patient can then take them from that point over. When she starts providing some of the extensive assist is when she starts putting her hands on and having to take some of that weight. So she's rolling the patient over. And you can see in the top one where you can see that the self-performance of a 3 with a 2-person, a 2 support, meaning she's doing it with 1 person support. Below, with the extensive assist, you can actually see there's 2 people having to scoot the patient up in bed, so that's a 3-3. And then another example of what we see very often every day is we're having to literally take the patient's weight, scoot their legs off the bed, and actually help them with their ADL. And then the total rolling. You have 2 people needing to roll her over. How many times do we have a patient that we're having to roll over because we need to change whatever they've soiled underneath them, and it requires 2 of us to do it because that patient cannot help us? That is a total dependence. If you notice, that patient's arms are curled in and they're not helping whatsoever. They're not even using their legs. And then here, total dependence, the patient's arms are across their chest. They're not even using their legs to scoot up in bed. So the person is now a 4 for self-performance, meaning totally dependent, and 2 people helped, so it's 3 for support. Here's the eating, independent. Betty is completely independent in eating and drinking. The tray was just provided, and after that, she's able to set up, cut up, open, do all of that. In this and the bottom one, the supervision, Betty is requiring some supervision for support, maybe for cueing, to ensure that she is cueing, that she is chewing at a level that is safe, that she's swallowing correctly, she's taking enough time, she's not scooping enough food, or she's not scooping too much food onto the utensil, and she's doing it at a rate that's very safe for her. In the limited assistance, you can actually see that Betty requires some staff to provide some elbow support to guide the elbow, but she's not actually having to lift the elbow, she's just guiding. With the extensive assist example A, Betty is requiring staff to lift her wrist so she can bring the food to her mouth. So she may have some weakness, but we're still allowing her to grasp the food and provide some finger food to be able to perform that task. In example B for extensive assist, now we're having to help lift the glass to her mouth so she can actually drink from it. And example C is Betty can feed herself, but she gets fatigued. She can't finish. So then the staff have to help her with that because of her activity tolerance is so low. And then example D, Betty can feed herself, but also requires tube feedings for adequate nutrition. So because she is dependent on the feeding device and she can't set up the feeding device herself, it requires another person to do it. It's considered an extensive assist. And then total dependent means Betty requires staff to feed all of her meal. So you are having to actually take every scoop and help her eat. With transfers, in the first example at the very top, Betty is able to stand with a walker from a seated position by herself. You can see there's no staff near her. She's able to perform the task all by herself and no loss of balance and no staff needed to help with any cueing or any kind of setup support. Now I want you to think about this. How many of our patients think about putting that walker next to their bed so they can do it themselves? How many times do we have to set up the walker for them before they go to bed or when they get out of bed? If we are having to set up that walker, it's now considered setup. Supervision, Betty requires staff to position the wheelchair and provide cueing and reminders to provide that transfer safely. With the limited assistance, example A, Betty provides staff to place the wheelchair next to the bed and provides hands-on guidance to transfer to the wheelchair. So the staff is providing some assistance and some guidance, but as you notice, they're not having to take on her weight. They're just guiding her to make sure she's safe. Betty's pretty much doing the majority of the task herself. And in example B, Betty requires staff for hands-on guidance to move from a sit to a stand with a walker. Again, they're not lifting her, they're not providing any weight bearing, they're just guiding her to ensure that she's able to manage and to place her hands onto the walker. Extensive assist, example A, Betty requires staff to partially lift and support her when transferred from a sit to a stand. This might be that situation where you have a patient who starts to wobble a little bit, and if you weren't there, they would have fallen. So again, a good predictor of a fall. In example B, Betty requires staff to partially lift and support her when transferred from bed to wheelchair. That's one of the hardest parts about a transfer, is when they're having to go from a sit to a stand, because it requires a lot of core stability and core strength to do that. So this is where we tend to have to help them a lot. Oftentimes after they've got to a standing position, they're able to do that transfer without as much assistance. It's usually from this point where they're having to require more assistance. So capturing that moment. An extensive assistance, example C, Betty requires staff to partially lift and support her for a stand pivot transfer from the chair to the bed, or from the chair to the bed, or bed to chair. Total dependence for transfers means that Betty requires at least 2 staff members to physically lift and transfer her using a mechanical lift. Remember, mechanical lift should never be completed alone. You need to have 2 people. Then when we come to toilet use, in the above example, Betty is independent with all her toileting tasks. She's able to do it herself. She doesn't need to turn the call light on for assistance with hygiene. She's able to do the transfer herself. She's able to manage her clothing by herself. She's able to do the whole thing. Supervision means that Betty requires staff for queuing for safe transfer onto the toilet. So she may have a little bit of difficulty, so we just kind of cue her that, bring your feet back a little further. Example B is Betty requires staff to remind her to pull down her pants prior to toileting. She might have some cognitive deficits and she may not remember that she needs to pull those down. So in order to prevent herself from wetting herself, we need to cue her to pull her pants down. And example A for limited assistance is that Betty requires staff to help her button or unbutton her clothing or her zipper prior to toileting or after toileting. And in example B, limited assistance, Betty requires hands-on guidance from staff to move from a sit to a stand or vice versa. So again, you're just guiding her. You're not literally having to lift, you're just guiding. Now, when it comes to extensive assist, that's when we are taking on their body weight. Remember that. So in example A, Betty requires staff to physically assist her with transferring to the bedside commode. So we are literally having to take that weight on. Example B, Betty is able to pull her pants down, bend her knees, and push her hips up, but requires staff to position her on the bedpan so that she doesn't soil herself and so that she's able to perform the toileting. Now let's say Betty has an incontinence episode and she's able to assist with positioning for personal hygiene and assist to remove and put on clothing. That will be considered a 3 performance and 2 support because one person needed to help her, but she still required extensive assistance. In example C, Betty requires staff to manipulate her clothing prior to toileting and provide personal hygiene. If a second person is required, remember that'll be a 3 for support. And then total dependence means that Betty requires staff to position her on a bedpan and provide total care for personal hygiene. So let's say Betty has an incontinent episode and requires total care for personal hygiene and clothing change. So we have now covered the Betty Handbook. Hopefully you guys will all carry that in your pockets for easy reference. Hopefully the pictures will help with interpreting. And if you have any questions, please make sure you contact your nurse supervisor, your case manager, or maybe even if you have questions regarding rehab, contact the program director or any of the rehab staff if you have questions. But just remember, it is important to always accurately code how much assistance your patients require to perform their activities of daily living. Code for the most support you provided during your shift, even if it only occurs one time.
We'd like to thank you for watching this video. If you have any questions, please go to your case manager of your facility, or if you have any additional questions for rehab, please contact your program director with your rehab care site, and they'd be happy to help you. Thank you again.